Hello, everyone, and welcome. Thank you for joining today's ONC Governance Update Program. This is Kate Berry, CEO of National eHealth Collaborative. NEHIC is a public-private partnership focused on encouraging widespread, effective adoption of health IT to create a more patient and family-centered system that drives better healthcare outcomes and better value. We play a unique role to convene healthcare stakeholders to tackle health IT challenges and develop practical tools and solutions to advance this mission. Within this broad mission, we focus on three major areas: health IT education, consumer engagement in eHealth, and health information exchange. Next slide, please. We would just like to highlight a couple of upcoming webinars in the next few weeks. On May 13th, we're going to have a deep dive into health information exchange and new payment and delivery models. This program will showcase HealthBridge and Quality Health Network and how they are leveraging their health information capabilities to support new payment and delivery models. And then on May 16th, we'll have another ONC program on the next generation of Blue Button. Next slide, please. And then on May 29th, we'll have another HIE program highlighting Coastal Connect from North Carolina and Healthy Link from Western New York. Next slide, please. We do also want to just make you aware that we're looking for consumer engagement stories, and you can submit those at the link here. Next, please. So you can access the slides for today's program at this URL, and there will be a recording available in just a couple of days. Next, please. And we're going to pause a couple of times during the program today to take your questions, do a little Q&A. So I wanted to just remind you all to type your questions into the Q&A window on the right-hand side of your screen as they come to mind. So now I'd like to, I'm very pleased to welcome our speakers for today. We have several leaders from the ONC team, as well as a couple of recent ONC grantees that are speaking today. Leading off, we'll have Dr. Farzad Mastashari, our National Coordinator for Health IT. We'll have Jody Daniel, Director of Policy and Planning for ONC. Claudia Williams, Senior Advisor at the White House on Health IT. We're going to have Steve Posnack, Director of Federal Policy for ONC, and Corey Mertz, Challenge Grant Director for ONC, as well as Mary Jo Deering, Senior Policy Advisor for ONC. And then we will also have Dr. David Kibbe, who's President and CEO of Direct Trust, David Whitlinger, Executive Director of New York eHealth Collaborative, and John Donnelly, President of Interpro Solutions. So as I said, we'll have a Q&A between each of the big sections. And I'd like to turn it over now to Farzad to make some opening remarks.
Thank you so much, Kate, and thanks for the eHealth Collaborative for bringing us all together. I heard that there were close to, something like close to 1,000 people registered for this call, which is just unbelievable. It's fantastic. So I think it speaks both to your efforts at creating an environment where people expect to come to learn the latest, but also to the great degree of interest that we have in the field as we're making progress. I think there are clearly challenges that are more sharply drawn now than they ever have been before as we learn more about what we need to do, and I think the folks here today will be able to provide some answers and to questions that that have been in line for a long time. Oh, is this the, let's go to the next slide, see what we get here. Yeah, okay. And let's go to the next slide. Okay, so we'll just, the slides are a little bit out of order, but that's okay. We'll just deal with it. Our overarching goal for Exchange is, when we talk about ONC having the statutory requirement to address governance, establish governance mechanism for the nationwide health information network, it's really, that's important for us to focus on what the goal is. And it's not governance per se. The goal really is that information follows the patient. And life-saving information follows the patient, regardless of organizational boundaries, regardless of vendor boundaries, regardless of geographic boundaries. And to accomplish that, I think we have to address several things. Obviously, we have to address some of the interoperability challenges and requirements. And the stage 2 of meaningful use has been a big step forward in terms of transport standards, messaging standards, content standards that are going to all take effect over the next 12 months. And we see software developers working very hard to implement those interoperability standards that are going to help reduce the cost and complexity of information exchange. We also need to improve the business case for information exchange so that it's profitable to share information, not hoard information. And we've, I think as part of the overall picture, both the federal government through Medicare and Medicaid, but also commercial payers have begun implementing new payment models that really start to turn the axis around, to flip the axis where it becomes more profitable to share information than not share information. And we recently got some really wonderful comments on our request for information from with CMS about what more we could do to push even harder on the policy and payment levers to make it even more of a business case. So those are two, but we also need, in order to make it just work, there need to be rules of the road and trust established. And this is an area where the governance issues become particularly keen as we move from first name basis information exchange to mechanisms where the rules of the road, the interoperability, the business practices, the privacy in particular requirements are standardized to the extent possible so that information can flow without the need for protracted and painful and sometimes expensive negotiations between every two parties who wish to engage in information exchange to help the patient. Next slide, see what we get. Okay. Next slide. And we talked about this. Yeah, and obviously governance issues are going to be more and more of a role as information exchange. I sometimes say we should have such problems. The more progress you make, the more sharply drawn the challenges and issues are. And I think we're now at a time when at least some of the challenges are very well understood, and I think it's now time to look towards some solutions for them. Next. And next. Great. And one more. So with that, let me turn it over to Jody, who will really take us to the level of specificity that we're going to start to have on our governance focus.
Great, thank you, Farzad. If you could go back to the slide that said ONC role, please. I think these are a little bit out of order. I just want to give a little bit of the context and the background for where we are and how we got to where we are, and give context for the two activities that we're going to be talking about today. So just to start off, ONC was identified, one of our responsibilities that were identified by Congress in the HITECH Act was for ONC to establish a governance mechanism for the Nationwide Health Information Network. We define the Nationwide Health Information Network as a set of standards, services, and policies that enable secure health information exchange over the Internet. So all of the activity that we're talking about today is in the context of this requirement and this important role that ONC plays in helping to facilitate electronic health information exchange in order to support the goals of making sure that information about patients is available where and when they need it. I'm not sure, there's a slide called Background on HIE Governance, another one. Yeah. There we go. So last year, ONC issued an RFI regarding a potential governance mechanism for the Nationwide Health Information Network. We really thought it was important to get some input on some of our thoughts before we went forward with a regulation for governance for health information exchange. And what we learned was that perhaps now is not the best time for us to engage in a formal rulemaking process, but instead we should really set up a series of activities that help us to better understand the activities that are going on the ground with respect to health information exchange and governance of health information exchange, as well as to better learn from some of the practices that are currently going on. We also heard from folks that there are some areas where it would be helpful to have a framework so that those who are struggling with some health information exchange challenges and those who are new to the area and developing new health information exchange and governance approaches had some guidance as to where to head, what to target, and some directionality, so that as those activities are occurring in the private out across the country, there was some alignment with respect to the direction and the framework for where they're headed. So next slide. Hopefully we should have a slide called non-regulatory approach. Excellent. So this is where we have gone. So when we decided not to go ahead with regulations at this time, we still wanted to address the goals that we had of increasing interoperability, increasing trust among participants in order to mobilize trusted exchanges that supports patient health and care, and decreasing the cost and complexity of exchange. So we have been engaging in a series of 4 different activities, and you'll hear about 2 of these in great detail today. So since our announcement in September that we were going to go forward with a non-regulatory approach, we have issued cooperative agreements, and these are grants to support specific exchange solutions. And you'll hear from Claudia Williams and Corey Mertz of our ONC team to provide some additional details, as well as from the grantees themselves today. Second, just last week we released a governance framework with a set of principles that focus on key areas where we think folks who are trying to accomplish governance for health information exchange should be focused. So they're in the area of interoperability, trust, organizational practices, and business practices. And Steve Posnack will be going into more detail and providing an overview of that later in the call. Third is the National HIE Forum, and NEHIC is helping to host and bring folks together as part of this National Health Information Exchange Governance Forum. The goal is to have a neutral forum to learn from and actively engage with entities that are currently serving in governance or oversight roles for groups of exchange partners. The forum will identify and shine the light on some good practices that support robust, secure, and interoperable exchange. And this forum has already kicked off and is underway with lots of good discussion and enthusiasm of the participants. And then finally is monitoring. We want to know how our activities are going and how the activities out in the field are going with respect to governance and health information exchange. And so we will be monitoring progress in the exchange ecosystem and governance activities in order to see if what we're doing is the right approach, if there are other things that we can be doing to help facilitate our goals of trusted exchange to support patient care, or if there are things that that we should step away from. So we're planning to monitor and keep iterating on our process and learning as we go. Next slide, please. It's entitled ONC's HIE Governance Definition. I think it was back a ways. I think we passed it. So people ask, what do we mean by governance? And here's our definition. The establishment and oversight of a common set of behaviors, policies, and standards that enable trusted electronic health information exchange among a set of participants. So this is, when we're talking about governance, what we are thinking about and how we're thinking about this suite of activities. And I have one more HIE governance focus is the slide. There we go. So I want to stress that we're looking at a national focus. There's a lot of health information exchange activities going on in various parts of the country, and we applaud all of the efforts to meet our goals of making sure that information is available to support patients and patient care. We're focused in our work on health information exchange at the national level to address challenges to exchange between different exchange organizations and across state boundaries. So again, growing towards a nationwide health information exchange effort. And we're not talking about governing the end users in the discussions and in this body of activities that I've been describing. So that's a background. We're going to go into some more detail on the cooperative agreements as well as the framework. And I will turn it over to Claudia Williams, who will give some remarks on cooperative agreements.
Thanks, Jody. This is Claudia Williams. I direct Health Information Exchange initiatives at ONC. And I have a very simple introduction and message today. First of all, hi, everybody. It's great to have so many folks on the line on a Friday afternoon. I hope it's as beautiful where you are as it is here. But just to underscore that the purpose of these cooperative agreements is to accelerate existing health information exchange governance activities. So to take that work, to shine a light on it, to help convene with those folks and in partnership with ONC, and to urge broad participation in these activities. So you'll be hearing more from both of our partners in this work. But what I just want to say briefly before they begin is please come participate. Please bring your issues and challenges to them. Please participate in the accreditation program that Direct Trust is launching and help them resolve issues that might still hang out there around directed exchange for stage 2. Please work with our New York partners to help them come up with best practices around querying provider directories, around patient matching, and around applying the principles. So ultimately, all of you out there, and the work you're doing, we urgently need your participation, your energy, your activity, your problems to be part of that work. So I would just, as an introduction, invite you to be thinking about the way in which you might be able to come to the table for each of these efforts as they talk. Follow up with us if you want to know more and connect into that work, and let us know if there are other issues that you'd like to be sure are addressed in this work. So with that, I will hand the mic over to Corey Mertz, who will give a little bit more background and information about both of these partners, and then turn it over to the partners themselves to talk about their work. Thanks a lot.
Great, thanks, Claudia. And I'll just run through this quick. But just as background, we put this funding opportunity and announced it out in December of last year. And this was really in response to a number of the comments to the request for information that Jody talked about earlier. One of the other themes we really heard from commenters was that the community wanted us to work with existing governance organizations that were out there in the field, already tackling a number of these issues. So this funding opportunity announcement was really our vehicle to be able to go out and work with those partners out in the community who are already, operational and addressing these issues, and have people at the table to work on them. So very excited to have these two partners. Next slide, please. They're going to be walking through the details of what they're working on, but we really focused with the cooperative agreements on wanting to work again to kind of develop and adopt additional policies, interoperability requirements, and business practices that are going to help tackle some of the biggest national challenges we see, and that also align with national priorities. We want to really focus this work in on reducing implementation costs and making sure the activities are going to assure the privacy and security of health information as it is moved. So really excited to have our two awardees on the line today to go in more detail about the work they're going to be doing, and want to echo Claudia's comments that we really hope the community is going to actively participate in their work and really help drive it even further and faster than it has been going already. So it's my pleasure to introduce our awardees today. Going first will be David Kibbe, the President and CEO of DirectTrust.org, and then Dave Whitlinger, the Executive Director of the New York eHealth Collaborative, and John Donnelly, the President of Interpro Solutions. We'll be talking about the work of the EHR-HIE Interoperability Workgroup. So with that, I will turn it over to Dr. Kibbe.
Thank you, Corey. This is David Kibbe. Can you hear me?
We can hear you, David.
Good. It's a pleasure to be here this afternoon and to talk with you about Direct Trust and the work that we're doing in the Exemplar HIE Governance Entities Program. I'm going to provide some overview of the work, but we're 7 weeks into this grant, and we can already report some progress to you in the main areas where we are charged to accelerate and advance direct exchange capabilities through scalable trust. Go to the next slide, please. So I think many people know that Direct Trust is a voluntary self-governing nonprofit trade alliance that is an outgrowth of Direct Trust, excuse me, the Direct Project itself. The Direct Trust started out as the Direct Project's Rules of the Road work group, and was and is dedicated to the growth of directed exchange at national scale through the establishment of a security and trust framework, which is really aimed at allowing multiple entities to bridge their security and trust policies across a very large group of organizations, including not just provider organizations, but patients and consumers as well. Can we go to the next slide? We have a website, directtrust.org. The member directory on the right will give you an idea of who we are. There are 63 or 64 members, I believe, as of today. We are health IT companies, provider organizations. There are a number of state HIEs, as well as some of their vendors who are health internet service providers, certificate authorities, and others. And please do visit the website, become a member if this is something that is important to you. We do need your help. We do need your contributions to solve, continue to solve some of the problems and issues that are really important to tackle if we're going to make it possible for any person with a direct address to communicate with any other person with a direct address in a manner that is secure and involves trust and identity. Next slide, please. So the major components of direct trust involve a certificate policy for X.509 digital certificates, which are the certificates that both sign and encrypt direct messages as they go from one HISP to another HISP across organizational boundaries and health IT vendor boundaries. We have established an accreditation program in partnership with ENAC, and this is now operational, and I'll be giving you some numbers in just a moment. We have received the ONC cooperative agreement at the end of March and hit the ground running. And we are also working on our Trust Anchor bundle distribution service, which is really operational as a 1.0 version now, and I'll also be giving you some numbers for that in just a moment. So the basic idea here is probably worthwhile going over very quickly, and that is that direct exchange is really a very simple idea. It's personal health information containing email transported over the internet between parties that rely on one another for security and trust and identity. And health internet service providers or health information service providers are known as trusted agents and work on behalf of the relying parties, who can be providers, they can be nurses, they can be patients or consumers, and they can be relatives or caregivers for patients and consumers. One of the very basic issues that makes this somewhat complicated, even though it's simple in terms of the protocols and the technology, is the idea that there needs to be some mechanism for establishing sufficient trust between the HISPs and their users and subscribers who are engaging in direct exchange. And more than technology is involved. The technical aspects of this are actually quite straightforward. But trust between two parties acting in an inherently insecure environment like the internet involves clarity and transparency and choice as to how the technology is deployed, as well as assurances as to how the relying parties are operating their environments particularly with respect to their security and the practices that they are engaged in that assure the person's identity in cyberspace or online is the same as their identity in the real world. If we do not do the security and trust and identity properly with directed exchange, it will lead to breaches of health information, and that would erode or undermine public confidence in directed exchange, and we do not want that to happen. So one way to achieve that assurance is to do it by accreditation. Accreditation is essentially a test that organizations voluntarily agree to take that involves, just as was said, I believe, by Jody, a set of behaviors, a set of policies, and a set of standards that enable them to, if successfully accredited, be recognized by others as abiding by those policies, behaviors, and standards. Next slide. So the priority goals within our cooperative agreement award, which we've been working on with ONC, and the collaboration has been, I think, to date, really, really good and very successful, and we've gotten a lot of guidance, and it's been very helpful. First of all is to increase interoperability and to decrease cost and complexity and facilitate trust among the participants using Direct for health information exchange, personal health information. And we always have to remind ourselves that really at the basis of all of this is the desire to improve care and coordinate care more effectively. The one thing I want to stress is that this isn't only about directed exchange. We're talking about point-to-point exchanges among and between known parties using a protocol, which is essentially email with attachments. Within that broad set of goals, there are in particular two objectives that we're working on very, very diligently. One is to advance industry engagement in the accreditation program that ENAC and Direct Trust have put together. Direct Trust can be thought of as the policy arm, the security and trust framework arm, ENAC as the infrastructure for doing the accreditations and the audits, aimed at health information service providers, certificate authorities, and registration authorities. These are the active trusted agents in direct exchange participants. And to date, we now have 7 organizations that have reached candidate status as HISPs, CAs, and RAs, and 1 organization that has reached fully accredited status as a HISP, CA, and RA. And we have 5 additional companies that have applied for the accreditation program but have not reached candidate status. That means we have effectively doubled the number of organizations who are HISPs that are in the candidate status category in the last 4 weeks. So our goal overall is to have 50 entities engaged in, fully engaged in the accreditation program by the end of the year. And we're well on our way to achieving that. However, it's going to take more work, and it's going to take a lot of outreach and communication so that we can help people understand why this is important and why it's valuable to become accredited. Which is a good segue into talking about the second area that is a high priority, and that is to design, build out, and operate at scale a trust anchor bundle distribution service that is really the payoff for being accredited. It transparently identifies the attributes of the anchor certificates from accredited HISPs and distributes these anchors to the public, thereby permitting trust relationships to grow at scale. This is what removes the need for costly, time-consuming one-off contract negotiations between HISPs or their users and subscribers. And I know that for most people, a trust anchor or a trust anchor bundle is almost a meaningless concept because it's not very familiar. But on the other hand, it's not very difficult to understand either. A trust anchor is a digital certificate which stands for and essentially validates other certificates that are used in this case for encryption and for signing of the direct messages. And if HISP A has HISP B's trust anchor in its trust store because it has gotten it from the bundle, and if HISP B has HISP A's trust anchor certificate in its bundle because it has gotten it from the distributed bundle, then when those two entities wish to exchange encrypted, signed, identity-validated direct messages, they know how to do it. And they don't have to stop and ask further questions about whether or not the parties involved are trustworthy or not. We now have a early but a fully functioning manual trust anchor bundle distribution service. If you go to bundles.directtrust.org, you can actually read about it, and you could, if you so desired, if you were a HISP, you could actually download and use and consume. I think there are 8 or 9 trust anchor certificates in that bundle now from organizations that are either accredited or are in candidate accreditation status. Next slide, please. So I think I'm going to stop here. There are some other slides in this slide set that you might find interesting that kind of go a little deeper into and behind the scenes of some of the concepts that I presented here. But the approach that we're following here for a national scalable trust framework is to, first of all, have a security and trust framework which involves those behaviors, policies, and standards that are mutually agreed to on a voluntary basis by, in this case, a growing number of participants in directed exchange who are HISPs and CAs and RAs. That is the basis and the fundamental building block upon which the accreditation program is built, because those policies and behaviors are what are tested for in the accreditation program and then audited against in the auditing portion of the accreditation program. And then finally, the successful accreditation status and recognition allows the entity's anchor certificates to be included in the trust anchor bundle and used and consumed by each other's HISP, but also a more widely distributed group of parties who need to know, have clarity and transparency about what these entities whose anchors are associated with them have achieved in terms of security and trust and identity policies and practices. I strongly invite you to participate with us. It's a good group of people. We have 4 active work groups. You do not have to be technically competent to be a part of Direct Trust because, for one thing, we need voices that are from all sorts of parts of the spectrum of people who will be using directed exchange, including providers and patients. So thank you very much.
Thank you, David. And I think David Whitlinger is up next.
Very good. Do you want to advance the slides? Yep. Okay. So I'm going to speak about the work of the EHR-HIE Interoperability Work Group, and then we'll jump to the details of the exemplar HIE governance project that we're embarking upon here. So first, a little bit of background. The New York eHealth Collaborative, in looking to drive overall adoption and usage of the state HIE network here in New York, ran across the same problem that many HIUs ran across in the early days of meaningful use and back in the 2010 timeframe, which was the high cost of integrating an EHR product to an HIE product and the broken workflow, if you will, if that integration wasn't done well, such that the EHR was able to query the HIE directly for records and consume them and use them and have that integrated workflow without jumping back and forth between applications and portals and so forth. So that led us to bumping into a number of other states through the different ONC collaboration efforts And collectively, we all got together at HIMSS that year and said, look, we all have the same problem. Why are we trying to address it all individually? Let's collaborate together and form a work group. So that kicked off at that HIMSS in that 2011 year with a number of states, a number of initial EHR vendors and HIE vendors who all embraced the idea of leveraging existing standards to develop plug-and-play quality interoperability between HIE and EHR products. And so that there was a firm recognition that there was enough standards development that was already done in the communities and in many cases in the products themselves, that as long as we reduced a lot of the variability that was allowed by those existing standards, that we could get to plug-and-play interoperability. Along that pathway, of course, the national standards emerged for direct. The query-based exchange standards evolved a bit from the Healthy Ways work that went into them, as well as we worked collaboratively on a common document format, and that all got packaged up and harmonized over the course of this period of time. Next slide, please. So here's where we stand today. Roughly 19 states are part of this interoperability work group. Roughly 50% of the population carried by those states. A number of EHR vendors, greater than 40 EHR vendors and 22 HIE vendors and 20 EHR vendors part of this program. And as you may know, the specs, we produced requirement specs, then we produced technical specs, then we produced testing specs, and then we issued an RFP to select a test partner. And all of that work occurred last year, and those technical test specs very, very detailed in order to be able to get to the plug-and-play level of interoperability. Over 540 test cases in some of those specifications in order to really get detailed in ability of matching interoperability very closely. Next slide, please. As entering into this organization, it was very important for us to identify what the roles and responsibilities would be in order for this to succeed. And as the states embrace the idea of wanting interoperability, there's obviously a need for the state to promote interoperability in order for that to be successful. So both through policy efforts and compliance efforts, but as well as marketing in their environment, in their state, the value of that interoperability and how that plug-and-play compliance testing, as we'll show here in a few minutes, as represented by a simple, easy-to-recognize logo, is valuable. And just to speak for New York, what we envision is this fall, as these products start to roll out with the logo and the tested brand on them, that what that means to the provider community is that they can now request from the vendor community that they want a state network certified product. In our state, it's called the SHINY, the State Health Information Network of New York. So a SHINY compliant product such that it'll integrate out of the box. And then, of course, on the vendor side, the ability to build that product, use the standards, and commit to developing a product that meets those standards. So we saw this as the work group came together as the vendor community very much interested in providing interoperability, but wanting to make sure that the customer base was there to support that effort and support the work going into making that and maturing that. And the state stepping up to the plate saying, we will market and make this a value in our marketplace if you do it. Next slide, please. So we got to the test specs last year. We partnered up with Healthy Way as they were transforming from the new HIN, and we jointly selected CCHIT as a testing partner to be able to do the actual engineering testing. And at this point, that those products from initial vendors are on their way through the testing processes in pilot. This set of organizations here, the Interoperability Work Group, Healthy Way, and CCHIT, has truly been remarkable at rolling up sleeves, solving engineering problems as they materialize, solving process and program problems, and getting to the point of really being able to issue the certification marks here in just a few short months. We also recognize that we're well into our own language when we work on this stuff, and that ultimately the end goal here was for the provider community to never have to understand what HL7 or IHE or any of these technical standards ever mean. Really is to boil that all up to a branded logo that says your product will work with the local network. So there is a white paper that was produced that you can see the URL for there. That white paper came out this last week where we're hopefully boiling it up for provider-level consumption. This is something that can then start to be circulated in the provider community that says, here's how this all works and why you should care about buying a certified interoperable product. Next slide. Here are the logos. So as we said, we're trying to get to the level where the provider community can just ask for the branded logoed product that says it's plug-and-play compatible with the local network, whether that's the Shiny here in New York or the HIE network in Wisconsin or what have you. Next slide, please. Okay, with that, I'm going to turn the baton over to John Donnelly. John has specifically been involved in the development of the Exemplar Governance Grant project that we're working on, and how this pulls together the provider directory efforts, both between our program and the direct folks.
Thank you, David. Good day, everyone. I'd just like to start off by just introducing how I kind of came into this a little bit here. I have been the representative from New Jersey as a member state of the Interoperability Work Group from its inception back in 2011. As a result of that, I've had the pleasure of working on a number of the work groups that have been the underpinning of the stuff that David just described, culminating in our current activities with CCHIT and standing up a testing body or conformance testing body, and with the objective of hitting those, getting those seals on products. Just want to emphasize that this has not been done in a kind of an IWG vacuum or even an IWG plus Healthy Way vacuum. We've clearly stayed as close and in lockstep with anything that's happened from the testing and certification programs that are focused on the meaningful use objectives and attestation for that. So objective here is not to have anything that seems to be off in its own technical space, but something that the vendors feel comfortable with as fully alignment with things that they need to do for that objective as well. And so with that, where we are now is actually even looking beyond the vendor's ability and the organization's ability to actually have stood up those technical capabilities. So what David described for the purpose of what we're doing now with the HIE governance project or grant project is that taken that they will have achieved that in terms of their capabilities technologically, and say, now let's look a little at the organizational processes, I think it was mentioned earlier, the behaviors and policies that have been layered into these organizations that are exchanging. And we know a number of these HIEs and HISPs have been doing this for some time, independent of whatever we've done from a technological standard standpoint, and we want to learn more about that. And this ONC has focused on two very specific objectives for feedback. and not by chance. One is in the direct exchange environment, and the other is in the more HIE, we'll call robust HIE query retrieve maybe model of exchange. And so the first one is they're very interested in some feedback with regards to how these communities will have stood up the utilization of a provider directory. And very interested to know, what is the mechanisms in place for querying and using that content that's in a directory in order to facilitate a direct exchange. So that's task number one, or activity number one. And the second is about the requirement and the concepts involving patient identity matching. Right, so I think everybody that's been involved with health information exchange and knows that that almost as a precondition of any kind of robust exchange, you have to have a way to reconcile the identification of a patient between one provider entity and another, between one HIE and another, and so they're very interested to know, how are they doing it? How are these operations doing that? And get some really empirical feedback on those processes. And as you see here, what we're looking to do is do this with some real one-on-one interaction or team interaction over the period of July to December of this year, and then provide reporting and feedback to the ONC and to each other, to the membership of the IWG and Healthy Way. And to that end, we anticipate also participating in any of these kinds of sessions and other ones like that over this window of time. So next slide, please. So to the first one here, and I guess they're inverted here. This is the provider directory pilots. We're looking to identify 5 to 7 pilot participants, states and their associated vendors, and to test their utilization of what has been done over the years in terms of technical standards, something called the Healthcare Provider Directory Plus standard model, and which is the same things you'll find out on the ONC S&I framework site, and also in our direct exchange specs. So there's no digression there or difference there. You'll see the same technical requirements there. But now we'd like to know a little bit more about the utilization of that by actual communities that have stood this up and are using it. And we know also, in parallel to this, we have an initiative from ONC called the Provider Directory Mod Spec initiative, and we have already begun a few sessions with them so that we definitely stay in lockstep and exchange where we are from whatever discussion and forum they might have with whatever we see out of our real-world deployments of a provider directory. And as I mentioned earlier, we want to take this result of these pilots in an open dialogue with our pilot participants, and not only put them into our direct specs implementation guide in the early part of next year, but also to have feedback and an active dialogue with ONC on this particular objective. Next slide, please. The second activity, if you remember, was about the patient matching aspect, and here we're calling this kind of a learning forum, because we are saying, okay, we have a specification for exchange. There is definitely guidance from a technical standpoint in terms of the mechanics of doing patient identity reconciliation. IHE has helped out with some of that, and a lot of that is incorporated into our technical specifications. But there is some kind of flexibility in that regard in terms of the patient demographics that might be used in a given community. And so as opposed to this being a health information exchange technical kind of assessment of where things are, it kind of drifts over into the health information organization aspect here, that what has that community set in place for its members in order to have a very efficient and effective way to share data, leveraging a patient matching algorithm that has been stood up in there. So you see some of the bullets here that relate to the characteristics of that reconciliation, and now we'd like to get some feedback. These things are in place. How is it working? where can we improve on it, where can we possibly lock down some of that in order to get a best practice feedback. So we're calling this a learning forum because we feel that a number of the exchanges of our members have been active in some of this regard, and definitely want to learn from that and share lessons learned, et cetera, in this regard. And again, timing-wise, we're looking to do that now through Q1, do our reporting around Q1 of 2014. Next slide, please. Okay, so the next steps, we see we have to finish our work plan with ONC, which is imminent. I think we've proposed something. We're just finalizing that with them. That'll happen within the next week here. And then we begin our recruitment process. We've already started to flesh out the mechanics of how we do that, inviting people in. And, you know, we started off thinking, okay, this is an IWG, you know, membership. We've got, you know, almost 20 states and 40 vendors to work with. And you know, one thing I did want to mention, you know, from the list of HIE vendors, we call the HIE vendors, but really that encompasses HISPs as well. So it's almost like HIE the verb as opposed to HIE as any kind of noun here. But we also see that, you know, we could open this up. This does not have to be restricted to just the IWG member states. For one, it could open the opportunity for other states to particularly join the IWG as a member. But even without that, there are clearly other health information exchanges in states that have not yet stepped up to be a member, and we certainly don't want to miss opportunities there. So this could be open to both. We'll then establish regular web conference sessions, and I think this is not something foreign to any of you that have been involved over the years. This is something that we've done through a lot of the ONC programs and IWG work groups, et cetera. And once we've had those teams established, we then, you know, fine-tune the work plan with each team to walk through that with the individual participants of the pilots and the learning forum. And that's kind of our immediate next steps. That's going to happen over the next 2 or 3 weeks, and you know, maximum of a month, because you noticed on the schedule, we're looking to have this all in motion by July. So we've got some recruitment work clearly that has a short time window to be accomplished. Last but not least on our list here is that you know, the IWG since its inception has grown, as was shown by David's slide there, you know, to quite a number of states and vendors. We have a good dialogue with the EHRA, which is the vendor community there. And so we're at the point where we really need to formalize our steering committee and our governance a little bit more than we've done up to now. And so those are things that we see as a parallel process that will be happening very quickly as well with regards to the IWG. So with that, I'd like to hand the baton maybe to Kate. I think maybe you want to see if there's any questions from the audience or any other.
That's right. Yep. Thank you. Thank you all. Very informative on these projects. So we do have a few. We're just going to pause for a few questions here before we go into the next agenda item, which will be Steve Posnack on the framework of principles. So we've got a few. First, I'd like to, I guess, turn to David Kibbe. So the question here is, in direct, can a provider pull a patient's complete record from all their providers? What specific information is provided, and can info be electronically sorted, searched, and read?
Okay, well, it's important to understand that direct is a set of protocols and specifications for transport. And it really is agnostic with respect to the contents of the message, which is really an email message, and the attachments that are also encrypted with the email message and sent over the internet in a secure and identity-validated way. So what the party who is sending chooses to send is it can be anything. It can be a structured, formatted file like the consolidated CDA or the CCR. It could be a PDF file. It could be an image. we know that under Stage 2 meaningful use, many of the messages that will be and attachments for support of transitions of care and referral management will be CCDAs and also human readable versions of those as PDF or HTML. And we know that the same kind of information will be going to patients under the patient engagement component of Stage 2 meaningful use in the view, download, and transmit. But it's important to understand that direct is really email, and it's not HISPs are not health information exchange organizations. They are health information exchangers. They perform health information exchange, but they HISPs do not open the envelope. They have no access to the content. They are simply a conduit that is performing very important security and trust functions.
Okay, David, I think I'm going to need to cut you off. We're short on time. I'm so sorry. Thank you for clarifying that. I think we'd like to go ahead and go to Steve Posnack. I think we are a little tight on time. It's late on a Friday, so why don't we go into the framework of principles? Steve?
Hi, actually, this is Farzad. Let me just say a word. So what we've heard, I think, is two groups that are working on, one, making Stage 2 meaningful use, which lets us communicate structured, codified data that can be parsed between different systems, make that come to life, right? So the taking care of the critical transport piece and the security and the certificates to make it just work. When you have in one EHR, someone has another EHR, being able to have those communicate with each other, or to have the patient be able to receive their own information and then share their information with whoever they want to share it with. That's a huge enabler, and it's going to be happening in the next few months, and we need to get on point to make that succeed, and figuring out the certificate management issues in particular is a big part of that Direct Trust is dealing with. At the same time, recognize that we need more than that, and we're working with the New York eHealth Collaborative and their efforts in conjunction to develop the standards of the future for making sure that query can work just as well, and having those issues, including some of the issues around provider directories, be addressed. So two streams of activity, both critically important and both much needed. The other thing that we heard, though, was what are the principles? What are the principles? And if you're not going to do it through regulations, tell us. Tell us what you think we should be doing. And so we've distilled down 3 or 4 or more years of work on this in what is now about to go in front of you in 4 PowerPoint slides. Steve.
Thanks, Farzad. And so this is Steve Posnack from ONC, going to cover the recently released governance framework for trusted electronic health information exchange. These are the 4 categories of principles. You'll actually see this numerous times, so hopefully by the end of my presentation you'll be able to spit them back at me pretty quickly. Next slide, please. Okay, so what is it? So what it is a set of ONC's guiding principles on health information exchange governance. And as Jody mentioned earlier, we had done a request for information on governance about a year ago, and a lot of the comments that were included in that request for information stated that an appropriate role for ONC would be to help people convene. So you just heard about 2 examples from our work with Direct Trust and the New York folks, and also to set direction and to explain our priorities to focus discussions on key issues. And that's really where we thought that releasing a framework that included principles for HIE governance would be an area that best fit those comments and in response to those comments. So the governance framework represents ONC's guiding principles for health information exchange governance. It's meant to provide a common conceptual foundation applicable to all types of governance models and expresses the principles that ONC believes are most important for HIE governance. So going forward, this is really going to serve as a pillar for how we approach governance issues with respect to electronic health information exchange. It reflects our current thinking as well as recommendations of the HCT Policy Committee, HCT Standards Committee, and as far as I've mentioned, draws from a wealth of ONC's prior expertise in a number of areas that really cross-cut this issue. So over time, we expect to update these and do so in response to folks' comments. Please go to the next slide. So the target audience is any entities that set HIE policy, whether it be state governments, public-private partnerships, health information exchange organizations, private companies, and is in general not meant to speak directly to the potential users of exchange services governed by such entities. We also believe that third-party assessors, whether it be through certifying or accrediting, may find the governance framework's guiding principles informative as they develop methods to assess competency, credibility, and trustworthiness of the entities that are responsible for setting HIE governance policy. Next slide, please. So here's just a slightly deeper dive of the organization, the principles that are included in the governance framework. There are 4 categories of principles: organizational, trust, and business and technical principles. I'm not going to read through the little synopsis here for these. I'm actually going to go to the next slide to dive into these. If you're able to access the governance framework document, which is on ONC's website at healthit.gov, you'll be able to get the full kind of preamble and discussion associated with the context for these principles. But again, looking at the organizational principles here, we were looking at this from the perspective of the way in which an entity that sets HIE policy performs its duties and how it behaves and governs itself. And so we set these principles forward in terms of our expectations and what we believe in related to transparency and openness, establishing mechanisms to ensure that their policies are applicable with federal and state laws, inclusive participation, including stakeholders, consumers, patient advocates, etc., ensuring consistent oversight and equitability, and providing due processes to stakeholders. Next slide, please. The trust principles, I think, is important to mention, are slightly different than the other ones, and in this regard, we chose to frame these principles from the patient's perspective. And what we believe that an entity that set HIE governance policy would be responsible for creating an environment in which patients should be able to do these things. And so they should be able to get a publicly accessible notice of data practices. So, and the kind of thumbnail sketch on this principle is really meant to be that patients understand what it is and why it is that their data is going to be used, in contrast to other types of notices that describe what entities are permitted to do with the data. We actually believe that these types of notices should be more descriptive in terms of what is actually done with the data and communicate that to patients. An explanation of privacy and security policies that are in place to protect their health information, be provided with meaningful choice, and we know that there are a lot of different ways that this can be accomplished. We're continuing to get recommendations from the HCT Policy Committee and its Privacy and Security Tiger team, but this is at a principle level a point that we wanted to say that this is something that ONC believes in as it relates to health information exchange. Be able to request limits in terms of the type of data or the source, and we have projects underway with respect to data segmentation and other such initiatives across the nation that folks are engaged in to get Part 2 data as part of electronic health information exchange. And so again, to express another principle that we hold. Fourth and fifth, I'm not going to go into in any great detail right now. Next slide. So business principles, this is not necessarily to tell health information exchange governance entities how to run business, what to do, more so framed from a perspective of how exchange can take place with patients' best interest in mind, and making sure that standards of participation that promote collaboration and avoid instances that would prevent patients' health information from being electronically exchanged, whether it be differences in fees, policies, services, contracts, kind of setting forth the principle that we believe in, that those things should not be an impediment to exchange patients' health information when the patients desire that to occur. Providing open access to exchange services, There are a number of different things that we believe, including provider directory data, et cetera, that will make it more ubiquitous and more accessible to different health information exchange organizations, and that's really at a governance level an important aspect. And then the third and fourth here, there is a need, as we received in the request for information, to better understand what people are doing, how many lives are being covered, the type of data that's being exchanged, the use cases that folks envision their health information exchange activities governing, and a commitment at large to be transparent about those things and to make that available to the public. So that's that third principle there. And then just a general responsibility to maintain and disseminate information that would be useful to their stakeholders with respect to relevant regulatory requirements, new standards, potential security issues, and best practices that come out with respect to health information exchange. And then finally, the technical principles. Next slide. Oops. Do we not have the technical principles? No? Yes? Can you go to the next slide? Maybe I got cut. So the technical principles. If you can go back one, I guess I don't. Okay. So the technical principles set the expectations of technical conformance and use of standards that an entity that sets HIE policy promotes. And so we really approach this to say that for the trust and business principles that I just covered, HIE governing entities should find ways to ensure that there are technical capabilities to support those principles. And then we really step through in the technical principles kind of a continuum where we express that where available, the entities that set HIE policy should stress the exclusive use of federally adopted vocabulary, content, transport, security standards that are adopted for electronic health information exchange. So really starting with the nationwide standards that have been promulgated through a variety of means, whether it be regulation or other guidance. When those aren't available, to then encourage the use of standards and associated implementation specifications that were developed by voluntary consensus standards organizations. So looking for open standards, consensus body standards that had been put out there. And then there are other such responsibilities that we lay out in the remaining principles related to leading engagement, helping to accelerate and volunteering to participate in pilots, use new standards when no such standards exist, and then take an active role in the development and implementation of conformance assessment and testing methods. So some of the activities that you've heard going on with some of the cooperative agreement activities that we are funding as well. So if you want to find out more information about our HIE governance activities, including the framework, you can go to www.healthit.gov/HIE governance, one word. And that will wrap it up to me, and I think back to Kate.
Thank you, Steve. And why don't we just roll into the governance forum discussion, and then we'll do questions at the end because we're tight on time. So Mary Jo, did you want to lead off?
I will, but so this is Mary Jo with OPP and ONC. And as we say in Washington, I may yield my time to the Honorable lady, Kate, who is going to give a few more details about the forum. And I think overall we will yield our time to the participants to ask questions because the forum has just kicked off. The real meat of this presentation to you was about the cooperative agreements and about this framework of principles, and we don't want to take time away from that. So the one thing that I will simply say is that you can see on this slide the categories of entities who are participating in the forum, and the fact that, and to emphasize again, as you've heard, that these are entities that really look across state boundaries and that have a certain scope. Their output is not going to be big P policies, and they're really not going to make us recommendations which we look to our federal advisory committees for those. But they'll do really important work. I am going to turn it over to Kate because as the head of the National eHealth Collaborative, she is facilitating this process, and she'll walk us through very quickly a little bit more about the forum.
Thanks, Mary Jo. So next slide, please. And again, we'll just keep this short. So as Mary Jo said, I mean, the overall goal of this forum is really to create an opportunity to learn and to share and to understand sort of what the best practices related to health information exchange governance are, and to sort of understand what the common approaches are, and perhaps where there might be some different approaches and some challenges, and try to collaboratively tackle those challenges, while of course always protecting the privacy and security. Next, please. So, just one level deeper, again, a collaborative environment for sharing among governance, HIE governance leaders, common understanding of key governance components, prioritizing those high-impact governance, health information exchange governance issues, and identify and sharing emerging best practices. Next, please. And finally, I think what we're really focusing on is understanding the landscape. What are the current governance practices and models, common approaches, common challenges, and then understanding where we need to work on some collaborative solutions to some of the challenging areas. I think that's it. Next, please. And so we do have a group that's come together a couple of times. We're meeting virtually roughly monthly, and we look to be developing this landscape, and the common challenges, common approaches. So next meeting at the end of this month, and the outcomes are posted, routinely on the National eHealth Collaborative website as well. So why don't we just open it up for the rest of the time. We have about 15 minutes or so on questions. So again, you can just sort of type your questions in. We've got a number of them here now on a number of different topics, since we've covered quite a few things. Let's see. There, we have one on sort of nationwide provider directories. Are there any thoughts, and I'm not sure who to direct this to, maybe it's a policy question for Jody, but any thoughts about using a nationwide provider directory that's linked to CMS payment verification?
Yeah, that was the question that we asked during the RFI about what we could do policies to increase interoperability, and we've gotten some comments back saying that potentially as kind of a poor man's nationwide directory, we could leverage the attestation process for meaningful use. So that's something that we're gonna take a look at.
Great.
Obviously, operational issues, and also lots of, it's not exactly what you want. You could have multiple addresses for the same person, multiple people with the same address, and so forth. But it's something we're going to look at.
Great. We have a question sort of as a provider, where can I go for basic HIE 101? And I know you all, ONC has a very outstanding website, but any comments on where basic HIE 101 information? Obviously, NEHIC does a lot of HIE-related programs, but comments from ONC on where we get HIE 101 information?
Yeah, we're actually very pleased with this 101, exactly that, interoperability 101 educational material we put up on healthit.gov.
Great. What will ONC do with the feedback from the I think IWG interoperability work group on provider directories and patient matching?
This is Claudia. Maybe I'll jump in, and then others can as well. So the sort of model that we're working with in these partnerships is that we're coming to the table along with the partner and inviting other people to come in. So there will be a whole set of activities with pilots to try out and pilot the HPD Plus standards, and to connect and query provider directories for directed exchange and other things. But the whole idea is that the learnings from that field work are not just helping the people who are in the pilots, that those learnings would be brought back into the S&I community, back into the policy committee, back to all of you as sort of both best practices and also what's not working. So there's a wonderful transparent feedback loop that we're inviting participation in these efforts and then bringing back those learnings so that we can refine our standards work and our policy work both through ONC and also directly with all of you in the community.
Thanks, Claudia. I guess maybe this would be for Farzad or Jody, I think. So the comment is, these are a lot of wonderful efforts to kind of advance health information exchange governance, but what's your vision for how all of these pieces will integrate over time into kind of a more cohesive governance approach?
Yeah, that's the goal, is for us to be able to first put out the principles, what we think is right. Next, work with organizations and trust kind of umbrella organizations to try out and to gain experience with the approaches to establishing rules of the road that the different information exchanges can feasibly use, and to engage in the dialogue where we learn from everything that's happening out there outside of those groups as well. And one vision of the future is that, like the banking network, ATM network, and so forth, that these networks converge over time with more standard operating rules and kind of coalesce into a national model. I will emphasize that one of the points that was very persuasive to us is don't do rulemaking until you know what the problems are that you're trying to solve, and don't freeze the market just as we're trying to get some interoperability going here. So I think that's we're not doing rulemaking with that. But if it turns out that at some point the evidence shows that there needs to be a federal rulemaking to do that, we're not going to be averse to doing that if that's what it takes. But I think our hope and expectation is that these kind of the analogy I used was kind of laying down singles to get around the bases.
We have quite a few questions that are coming in that relate to patient identification. So, do you think we can, come up with best practices for patient identity matching algorithms?
Yep. Well, I think there's been actually 6 or 7 different areas of activity that we've done over the past several years on this, and I would say that we need to work first on the attributes that we do matching on. What are the standards for those attributes? How do we represent date of birth and name, and clarify, is the ability for private sector partners to use Social Security numbers, or should we use phone numbers, or what are the attributes that we use for matching? 2, and probably most important, is to get upfront much better ways of collecting that information. So I will posit to you that if everybody had collected the demographic variables and had checked address against the Postal Service and checked Social Security numbers against the Social Security Verification Service and had 100% complete data on all the matching fields, we wouldn't have much of a patient matching problem, either internally or externally across sites. So really getting to workflows, best practices, working with groups like AHIMA to have those implementations in the boring kind of registration process, best practices, document management stuff. And then third is thinking about new services, algorithms for creating voluntary patient IDs, disseminating, and things like what Commonwealth is doing, and other similar activities, potentially people using their direct addresses for their personally controlled health exchanges as their unique ID that binds them across settings. But I think the first 2 steps that we're going to take concrete action on over the next 12 months is going to be, what are the attributes used for it that we can move forward on that everybody should be using for matching purposes in a standardized way, and then how do we work with folks on the front lines to improve the quality of data collection, and it is a safety issue.
And on that same topic, a couple of the themes are also saying, well, what about the National Patient Identifier? Any comments on that?
Well, like I said, I think, we can't work on it because, congressional mandate. If other people want to set up private sector voluntary patient ID schemes, I think that's fine. But if we think about it, every patient on Medicare has a unique patient ID. So let's start with that part of our population to make sure that we never have a false match or duplicate record for patients on Medicare. Why don't we start with that and see what we can do today with what we can do today.
What do you think about how going forward we can align the state-by-state efforts with the ONC national framework that was just talked about and the national agenda?
Well, I think actually working with groups like there's a Southern State group, there's the Western States group, there's the New York group, right? I think the state leadership can be actually really, really critical here, and to get those pushing the boundaries and also working on the cross-state collaborations, but hopefully doing it engaged with and in touch with these governance activities. Corey, Claudia, anyone else want to comment on that state piece?
Nope, that sounds great.
It looks like we've covered most all of the questions, and we just have a few minutes. Farzad, would you like to just make any or anyone else any sort of closing comments?
I mean, I'll just emphasize again, this stuff, and I like what Dave said. This stuff has just got to work for the providers on the front lines. They can't be thinking about the X509 certificate or the trust bundle or the DURSA. It's just got to work for them. So part of someone, I think it was Oliver Wendell Holmes, said, I wouldn't give a fig for simplicity on this side of complexity, but I would give my right arm for simplicity on the other side of complexity. And this stuff is complex, and we can't solve it by unnaturally simplifying it and assuming that we can't deal with the complexities around trust or interoperability. But the better we get at this, the more we kind of hide the plumbing, and the more we have services that create simplicity for the end user, the closer we'll get to what patients deserve, and reduce the burden on providers. So I really urge folks who've been participating and listening today to take concrete steps as they get ready for Meaningful Use Stage 2, where they're thinking about a service, or their healthcare providers, technology vendors, to take practical steps today to say, how am I going to get to the point where 12 months from now it just works for the people that I serve, the patients that I serve, the customers that I serve, the providers that I serve. And I would recommend that a good first place to start is taking a look at the principles here and saying, am I doing these? Is there a good reason? If I'm not, is there a good reason really that I'm not following these principles? And for them to look at the organizations and say, do I have a means of exchanging information with other information exchange entities? And if I'm not a part of one of these consortiums, why not? And how do I think how am I going to be participating in this if I'm not part of one of these organizations?
All right. Thank you so much, and thank you to all of our speakers for sharing all the great work that you're doing, and thank you to everyone who attended this. It's been very, very informative and lots of good, thoughtful questions. So with that, I'll bring the program to a close, and I hope you